Good evening, everyone, and welcome to the EUROGEN educational webinar series. Before we make a start, I would just like to introduce myself. My name is Michelle Batty, and I'm the manager of the EUROGEN network. I'd first like to say a couple of words about what a European reference network is. Well, ERN EUROGEN is one of 24 reference networks which cover different medical fields. They were created by the European Commission in 2017, and we deal with patients with rare urogenital diseases or complex conditions that require highly specialised healthcare. So really where the expertise is rare. And as a network, what we try to do is deliver faster evaluation and more equitable access to high quality diagnosis, treatment and care for those patients with a rare or complex urogenital disease. And some of the things that we do, just to give you an overview, is some of our activities. Well, we collaborate using the clinical patient management system, which is a new IT platform which allows us to conduct fully secure European level MDTs with our experts. And we can provide that advice to any healthcare professional in any European Union country. So if you do have a rare or complex case and you would like our advice, it's free. So please don't hesitate to get in touch. We're actually really keen on testing the new tool. So feel free. We also collaborate in education and training, such as these webinars, and we also run a new clinical exchange program where we move people between our hospitals, which is just under pilot at the moment. And we are also, this is a very exciting recent development, we're working on developing a EUROGEN registry, and that is going to go live next year. So, of course, we're hoping that that will pull together new real-time clinical evidence, which will be available for research purposes. If you want to know more, please, I would recommend you visit our website and don't hesitate to get in touch. So this webinar this evening is held in collaboration with another ERN, ERNICA, and also the ARMNet network. So we're really happy to work in collaboration with those organisations, and I'd like to thank them. So without further ado, let's head over to our presenters this evening. We've got a real treat for you. Two of our experts in anorectal malformations and Hirschsprung's disease. So we have Pim Sloots, who's a paediatric surgeon at Erasmus Medical Center Sophia Hospital in Rotterdam in the Netherlands. And he's an expert in anorectal malformations, Hirschsprung's disease, colorectal surgery, and he's been with the ERN since the beginning, so a warm thanks to him. And Pietro Bagolan, another one of our leading experts, who's also a paediatric surgeon, and he's director of the department medical and surgical for fetus, newborn and infants. And of course, they deal with all the congenital anomalies. And he's in the Bambino Gesù Hospital in Rome. So gentlemen, thank you so much for giving us your time and sharing your expertise with us. And I'll now hand over to Pim, and thank you very much. I hope everyone enjoys this evening's webinar. Thanks, Pim.
Thank you very much. Can you hear me?
Yes.
Can you see my screen?
That's fine.
Yes, great. Thank you very much for inviting me for the webinar on anorectal malformation, rectal urethral fistula in males. I hope you're all well in the continuing COVID pandemic. In the Netherlands, we are back in a partial lockdown, trying to get the spread of the virus under control. Concerning the subject of today, anorectal malformations, I do not think there's a relationship between a maternal or paternal coronavirus infection or the medication used and the incidence of anorectal malformations, since we do not have more cases than before. Remarkably, we do see more cases of meconium peritonitis, but that can be due to chance, and that's not of the subject today. But if others have this experience also, just let me know. I'm very interested in that. So today we're going to talk about a few things. There are a few things Professor Bagolan and I want to handle. First, I'm going to present a case showing the different aspects of anorectal malformation type bladderneck fistula. And then Professor Bagolan is going to explain the things later on. So I want to present you a case of a boy born 4 months ago in Sophia Children's Hospital, Rotterdam. In our hospital, the perinatal gynecologists are very much interested in prenatal diagnostics, not with the reason to terminate an issue stated to me by patients' organizations. However, the reason for the prenatal ultrasound is, and we think it's important to be well informed to detect the anomalies in the fetus and to be prepared for the postnatal treatment. Also to counsel the parents and to try to avoid a postnatal roller coaster of actions and emotions and changing of hospitals. So in our case that I want to present to you, there was seen a single umbilical artery from which we know can be associated with other congenital malformations, such as anorectal malformation. There was seen a kystic dysplastic right kidney, a genital malformation with a mega ureter, distended bowel, and an anal atresia, high diaphragm, and a double bubble. And there was seen a polyhydramnios. There was performed genetic study of the amnion fluid, which show it in XY male chromosomes, and a whole exome sequencing did not show a gene defect. So we have a growing interest to study the anal canal on prenatal ultrasound. In the right upper panel, you can see the image of a normal fetus with her legs over here. And you can see clearly the anal opening, this sphincter complex and the anal cushions within. We call it the target sign. On the footage, which I will start. Yes, that's running. On the footage of our case, you see the male genital with a hypospadia and a perineal crease without a target sign, giving rise to the suspicion of an anorectal malformation. So you see the genital, you see here the crease, and there's no target sign there. So I've made a poll for you. Maybe you're willing to answer the question in the poll. There's no right or wrong. I'm just curious what you do. So as in your hospital, the ERNs studied at the prenatal ultrasound, looking at the target sign, and the answers are simple, just yes or no, I don't know. I have another example for you for the prenatal ultrasound. It's a child with a multicystic kidney, from which an anorectal malformation was picked up, the vestibular fistula. So if I start again, you can see the rectum here, and in the crease, there is no target sign because the rectum is quite low.
Pim, I guess that everyone now sees the poll because I just launched the poll. So maybe you should wait a little bit more with the ultrasound.
Oh, but I'm all right. Okay.
Yeah. I'll give you all 10 more seconds to vote and then we'll close the poll.
So importance is if you want to introduce this in your hospital, you have to explain what an anorectal malformation is to your prenatal gynecologist and explain the different types so they can look at it at the 20 weeks or ultrasound or later on in the pregnancy.
And the results of the polls are that 44% voted no and 25% voted yes. 31% don't know.
Oh, that's great. So people are starting to recognize this prenatally. I'm very happy with that. So the advice is if you have some multidisciplinary like a conference, then keep on asking for this target sign. So we go further with the case. Postnatally, on physical examination, there's a flat bottom, there's no anal opening, and a proximal hypospadia. And there's no meconium in urine. So we made an X-ray of the plain abdominal X-ray, and the double bubble is confirmed, and that can be the explanation that there's no meconium in the urine, because this could not pass due to the duodenal atresia, since bile pigments cannot pass. Surgery is planned without the duodenal atresia. Surgery should be done within 24 hours, certainly in combination with disorders as esophageal atresia or diaphragmatic hernia. However, with the duodenal atresia, you have more time. It's not a big rush to go to the OR. So we did a transverse laparoscopy. The duodenal atresia is repaired, and the rectum is found to be very wide, filled with a jelly-like urine, as shown in the picture from mucus fistula. So the proximal loop is brought out in the laparotomy wound and the distal mucus fistula as a step incision. Testes were in the abdomen. Since no urine catheter could pass, due to proximal hypospadia, a suprapubic catheter is placed. So in this case, the kidney is protected by the recto-urethral fistula, filling the rectus sigmoid with urine and giving relief to the kidney. Genetic consultation is warranted to find a syndrome such as Down or other. However, antenatally, chromosomes, SNP array, and WES could not reveal a genetic cause. Anorectal malformation, rudimental finger and cleft hand, dysplastic kidney, and hypospadia could be within the vector L association. However, duodenal atresia is not. Otherwise, not all congenital abnormalities which are found in anorectal malformation patients, such as congenital diaphragmatic hernia or malrotation, fit in this association. Next step is to get more information on anatomy of the anorectal malformations. It would be to perform visualization studies. A colostogram, inserting contrast in the distal colon by the mucus fistula or filling the bladder, and then filling the colon via the fistula, can be performed to show the level of the rectum, and if there is a patent fistula. In our center, we are used to make MRIs with the technique described in the article. The baby is fed and wrapped before the MRI, therefore it can be done without sedation. The advantage of MRI is that it does also visualize the surrounding structures. The downside is that the rectum is not filled, so maybe it's harder to check if it can be reached by a PSARP. So I have another question for you. He has shown the contrast study with the contrast medium brought into the bladder via the suprapubic catheter. I just want to ask you, what do you think about the level of the fistula? So how would you classify the anorectal malformation? Is a bladderneck fistula, a prostatic fistula, a bulbar fistula, or no fistula, or I don't know and can't see? I just want to mention the study of Paola Midrio, which is recently published, where she reviewed to what extent it's possible from this kind of image to determine the location of the fistula.
I give you 10 more seconds to vote.
10, 9, 8. Happy New Year.
Yes, well, we've got about 70% of people that voted now, so I'm going to close the poll.
Oh, great.
35% says it's a bladderneck fistula, 31% says it's a prostatic fistula, 10% a bulbar fistula, and 21% doesn't know.
Okay, thanks for your answer. Most people think of rectal bladderneck fistula because of the title of this presentation, of course. But when I read from the contrast study, is that the dilate proximal urethra is filled, is shown, as well as the recto-urethral fistula running to the dilated rectum. You can see here. I would say it's a high prostatic. On the artist impression, this one, it's the bladderneck fistula shown somewhat more higher. However, the prostate is not shown in this diagram, but if you see in this image, on the anatomic drawing, I would say the fistula is somewhere over here. However, it's hard to say because you only see the contrast in the lumen and you don't see actually the surrounding structures. Maybe a pressure colostogram could delineate the fistula maybe better, since this is filled via bladder. So I want to show you the MRI of the child. On sagittal picture above the symphysis, the bladder is seen with dorsally the rectum. So this is bladder, the symphysis, and here is the rectum running to here. This fluid-filled structure is the dilated right ureter. So the fistula is seen just below the bladder neck, where the widened urethra is shown below this level. On the transverse images, the bladder can be seen anterior with the posterior, the dilated ureter and the rectum. So this is the bladder, dilated ureter, and here is the rectum coming, entering the urethra at the split prostate level. So here is it entering the urethra. And most distally, you see only the urethra left. From the MRI, one could suggest that the rectum can be found behind the sacrum from a posterior sagittal approach, like this, going here. And the fistula is reachable. However, for mobilization of the rectum, an abdominal approach can be of help. So I just want to ask you another poll. What kind of approach you would do in handling such a case? So posterior sagittally, PSARP, laparoscopically assisted, pull through, LARP, laparoscopic mobilization of the rectum and a PSARP and taping of the rectum because it's very wide. LARP and resection of the right dysplastic kidney because this urethra is very wide and the kidney is not a function. A LARP resection of the right dysplastic kidney and a Follis Stephen oculopexy in one session, or none above. I think the poll is open now.
Yes, the poll is open. There are already almost 50% of the people voted.
Oh, great, because it's a very difficult question, I think.
Okay, give you a few more seconds to answer. Okay, well, 49% says a laparoscopic mobilization of the rectum and PSARP, 21% PSARP only, and 21% a laparoscopic pull-through, and 7% would do a LARP and a resection of the right dysplastic kidney.
Okay, great. Yes, there's of course no truth or wrong. This is just how you would approach this problem. So in the reconstruction of this complex anorectal malformation, it's important to be informed maximally. A PSARP could be feasible to reach the rectum just behind the sacrum and to close the fistula as close to the urethra as possible. Be careful of the dilated urethra on the right side. Via PSARP, mobilization of the rectum is very hard, but fixation of the rectum to the weak pelvic floor is better. From a laparoscopic approach, it's easier to identify the structures, mobilize the rectum. However, closure of the fistula just at the urethral level is more demanding since it's around the corner at the upper side of the laparoscopic view. Also from laparoscopic view, the right dilated urethra can be seen in the similar case. So there's another case, and where you see is this is the bladder. You see the rectum here, and if we lift up the bladder, yes, this is the rectum running down to the pelvis. This is a dilated ureter, and the fistula should be somewhere here below the bladder. See the rectum is running here low down to this fistula. Surgery of this complex anorectal malformation is challenging and functional results are poor. Short-term complications consist of rectal prolapse, here this example, since the pelvic floor is very weak. Otherwise, when the anal opening is made too small or the rectum is stitched under great tension, a stenosis can occur. When the stoma is reversed, severe dermatitis can be a problem. It's important to remove the fistula as much as possible close to urethra, without narrowing of the urethra itself. A remnant of the original fistula, abbreviated as roof, ROOF, can be a problem, certainly combined with a stenosis in the urethra. The roof gets dilated, and even after many years, it can give symptoms such as dribbling, discharge, and recurrent infection. Here you see the MRI of a 66-year-old man after correction of the anorectal malformation and later removal of the rectum due to dysfunction, but with a persistent cavity behind the bladder, which started as a roof. So this is bladder and this is a cavity. Finally, surgery, including removal of the bladder and filling of the cavity with omentum, was needed to treat the infections. The bowel function and bladder function are known to be poor, needing bowel management with retrograde or anterograde enemas and treatment with a treatment of the neurogenic bladder. This case, which I presented to you, has extra issues. The case has a dilated colon due to urine overflow together with a stenotic urethra. Probably the overflow saved the left kidney. However, from the dilated floppy rectum, it cannot be expected that the propulsive function is good. One could consider to taper the colon before pull-through, or when only the sigmoid is dilated, to remove this part, leaving the rectum as the reservoir. We are not yet informed about the bladder function. Aerodynamics are difficult in its young age. However, corrective surgery close to the bladder neck and prostate will not improve it. The dysfunctional kidney and dilated urethra are to be removed, leaving one kidney behind. Maybe the right urethra can be used as a channel for intermittent catheterization later on. Furthermore, around the anorectal malformation is a patient, and the patient has an intellectual development, and that is to be awaited, which could be of influence of the potty training later in life, and other malformations such as limb abnormality could influence functioning. Luckily, the duodenal atresia repair healed well without any problem. Thank you for the interest in the case presentations. Now we're going to leave the cold and rainy Netherlands to Prof. Bagolan, Chief Surgeon in Bambino Gesù in Rome.
Okay, it's okay now?
Yeah, that's pretty good, thank you.
Okay, thank you to you. So, fistulae of the urinary tract are the most common findings in males born with an anorectal malformation, and the anatomy distributes across a spectrum of disorders with wide-ranging complexity, which affects the surgical management, the rate of associated anomalies, and also the long-term functional outcomes. As such, the term recto-urethral fistula is insufficient in describing important information. Animation shows the sagittal view of the anatomy of the pelvis from a normal human being to a recto-bladderneck fistula, passing through the recto-bulbar, the recto-prostatic in yellow, and the recto-bladderneck in blue. In the left side, you see a figure reported by Mark Levitt in 2015 and used for educational purposes to correlate findings on the distal colostogram with identification of the precise location of the rectal fistula. Again, rectobulbar, green, rectoprostatic, yellow, anorectal bladderneck fistula in blue. In the patient with the rectal bladderneck fistula, the sphincter mechanism is very tenuous, as you can see here, comparing with here and here, and sometimes is also non-existent, and the distance between the sacrum and the pubis is very short, as you can see in the here. If you look at the bowel control in these different anatomic types of arm, we see that patients with rectoperineal fistula have a 100% chance of bowel control, while those with a bladderneck fistula only 20% or even less. Moreover, as expected, the incidence of the associated defects is highest in these patients, as reported in this slide, up to 85% for sacral and vertebral anomalies, almost 90% in urologic anomalies, 1/3 of patients have an absent kidney, and 45% have an ectopic verumontanum. The verumontanum may be located in the trigone, in the bladder neck, or below the bladder neck. Vesico-urethral reflux is reported in 45% of patients. We should be also aware that other potential serious conditions can coexist, such as the gastrointestinal associated defect, 15% esophageal atresia, the neurosurgical defects, with 32% of patients having a tethered cord, cardiac defects, with 15% of atrial septal defect or patent ductus, and other defects of the hand and extremities. At birth, evaluation before the main operation should include a rigorous clinical examination together with an X-ray of the spine, sacrum, and forearms, as Pim has showed, and also an abdominal ultrasound to rule out renal anomalies, an echocardiogram to rule out cardiac defects, and spinal ultrasound or RMI to rule out tethered cord. As far as the clinical examination is concerned, this complex malformation may be suspected when we see a flat bottom where the midline groove is not present, and also we frequently see a sphincter mechanism that is positioned at the base of the scrotum. Finally, the presence of a bifid scrotum also suggests that the malformation is complex, most likely very high. The diagnosis is then confirmed only with a distal colostogram and subsequently by a cystoscopy that is performed at the time of the main repair. Another important step of the preoperative assessment is the radiological evaluation of the spine and sacrum to calculate the sacral ratio and rule out vertebral anomalies. Here, you can see how our sacral ratio is calculated. First, the first line is drawn between the most upper portion of the iliac bone in an anteroposterior view. Then a second line is drawn between both the inferior and posterior iliac spines. And finally, a third line is drawn parallel to the first two lines, touching the lowest radiologically visible point of the sacrum. So the distance between A and B and C is measured and the ratio calculated. So a good sacral ratio is defined as a ratio greater than 0.7, while a poor sacrum is defined as a ratio less than 0.4. We know that the development of the sacrum is also predictive of continence potential, and it is ideally calculated after 2 or 3 months of age. So when clinical and radiological assessment raises the suspect of a rectobladderneck fistula, the colostomy is then the first step to be performed at birth within the first 24 hours of life. And attention must be paid on being sure that we have enough length on the distal colon to have the opportunity to perform the pull-through without interference by the colostomy. When clinical and radiological assessment, distal colostogram is performed through the mucous fistula to study the distal rectal length and anatomy. So a number 8 Foley catheter is introduced through the mucous fistula, and the balloon is inflated with 2 milliliters of water. Traction is applied to prevent the leak of the contrast, and then the injection of the contrast is done. The injection continues to reach the most distal part of the bowel. At this point, we obtain in an anterior-posterior view a good information related to the length of the bowel available for the pull-through. The injection then continues with enough hydrostatic pressure to overcome the muscle tone. The rectum is then distended and the real site of the fistula is showed. When and if the baby has a rectobladderneck fistula, the contrast goes into the bladder directly in a rather easy way with a minimal hydrostatic pressure. The cystoscopy can be extremely helpful to learn about the anatomy of the male urethra, bladderneck, and trigon, the veromontanum position, and the possible definition of an ectopic ureter closer, below, or in the bladderneck have also to be evaluated. Finally, the Foley catheter is placed before starting the procedure. Before laparotomy, the total body preparation is done. This means that the entire lower body is included in the sterile field. Cautery plate is placed in the back of the baby. Arms of the patients are placed in the upward position. Legs are covered with bandage, and stoma of the colostomy is packed with an antiseptic solution. Finally, the skin of the abdominal wall is covered with a plastic drape. The operation can start either from below, a posterior sagittal approach, or through the abdomen. And we now more often approach the abdomen first, which can be done by laparotomy or laparoscopy. We consider, in fact, that the bladderneck defect is a good indication for a laparoscopic approach. The abdomen can be entered through a lower midline incision or through a phanesal incision also. A clamp is placed on the urachal remnant of the bladder to apply caudal traction in the bladder. The posterior wall of the bladder is now so exposed, as well as the peritoneal floor, the sigmoid, both vas deferens and ureters. At this moment, a further traction is applied on the sigmoid, as you can see in the the picture, and dissection is done as close as possible to the bowel. And so within a centimeter or two after our initial dissection, the bowel decreases in size and becomes very narrow, indicating the location of the fistula. So the fistula can be closed with a 5-0 absorbable suture. Now, once the rectum has been separated, it may happen that it is not enough long to be pulled through. We all know that the rectum has an excellent intramural blood supply, so we can elongate a distal colon by ligating vessels but maintaining peripheral vascular arcade, as is shown in this animation. Sometimes we are not limited by the vessels, but by the colostomy itself, as is shown in the figure number 2. So we must take the colostomy down, taking down the mucous fistula, also leaving the upper part of the pull-through rectum closed, bowel closed, the so-called Hartmann pouch. A further option can be pulling through a short piece of the rectum with a colostomy closure and opening of a more proximal colostomy, as observed in the figure number 4. And lastly, we can also close the colostomy, leaving the patients without a protective colostomy, a coronary anastomosis in the pelvis, central venous catheter, and total parenteral nutrition for 15 days. We are now ready to perineal approach. We can be done in 2 ways. One, simply lifting the legs up, putting a bulky roll below the pelvis of the patients. The perineum is then well exposed and we can work comfortably. The incision runs from the base of the scrotum and about 5 centimeters posteriorly, because this exposure is enough to create a safe abdominal perineal path. Once the abdomen is entered, a clamp is passed to grasp the distal end of the bowel previously dissected, and the anoplasty is performed within the limits of the sphincter. The second day, as Pim said, is the classic posterior sagittal approach. The laparoscopic approach was first proposed by Willittal in 1998 and then popularized by Professor Georgeson in 2000. Laparoscopy is aimed to minimize the trauma and the pain that are produced by the incision of the abdomen. At the same time, the exposure of the peritoneal floor is really excellent. The dissection of the distal rectum is easily done. However, the division of the fistula cannot be done as accurately as when it is done with a laparotomy. The separation of the rectum from the bladderneck and the ligation of the fistula are easy, since we know that the higher the fistula, the shorter the common wall. However, selected mesenteric vessel coagulation may be not as accurate as with an open abdomen, and in addition, when the rectum is too dilated to be placed within the limits of the sphincter, the tapering of the rectum is required, and the laparotomy may be preferred in these cases. Some surgeons believe that laparoscopy is primarily indicated only to replace a laparotomy, so when the abdomen has to be entered. If this is true, in male patients with anorectal malformation, no more than 10% of require a laparoscopy, and specifically those with the recto-bladderneck fistula. It is important, however, for surgeons to realize that the incidence of residual fistula, as you can see in the animation, may be higher in laparoscopic assisted than in PSARP, in particular in those anorectal malformations with a long common wall between the urethra and rectum, as the recto-bulbar fistula are. So the incidence of remnants of original fistula could be underestimated because most are asymptomatic and may be overlooked if not investigated. However, as you can see here, many studies report a higher incidence of roof in LARP when compared with PSARP. Also in this more recent paper from Tanaka and Ishimaru. A further complication reported following LARP is the rectal prolapse. Two recent systematic review and meta-analysis, including 130 patients with LARP and 164 patients with LARP, did not show a statistically significant difference in postoperative rectal prolapse between LARP and PSARP. On the other hand, several studies reported a higher incidence of prolapse in the patients with after LARP, as you can see here, 50% compared with 0% or 50% compared with 29%. Lastly, the fecal continence. Two meta-analyses have dealt with the essential issue of fecal continence. The first published in 2015, the second in 2017. Both did not find a significant difference between PSARP and LARP regarding fetal continence. However, some concerns were raised, especially in the second meta-analysis, the first one that various assessment scores were used to evaluate fecal continence. Most studies included different type of arm and analyzed this type of arm altogether. And finally, many studies enrolled also patients younger than 3 years old who seems really to be too young for toilet training. Subsequently, many different studies reporting long-term outcome have been published. By and large, fecal continence outcome after laparoscopic assisted seem not to be inferior to those after PSARP. However, so far, LARP has not improved functional outcome. So to conclude and to give you some take-home message, the recto-bladderneck anorectal malformation is the dark side of the moon in the arm in the male. No more than 20% of these patients can achieve a bowel control. Colostomy is still required, and attention must be paid to have enough length in the distal colon. Preoperative uretroscopy is strongly suggested to rule out or to focus urologic anomalies. Laparoscopy is a good indication in these patients, even though roof and prolapse still seem to be a higher incidence in LARP pull-through. Thank you so much.
Thank you, Pietro, and thank you, Pim. I don't know if you both put your cameras on now. That would be great. So we'll take some questions. If people have any come in during the presentation, so I'll give people a few minutes now to start typing them in. Just got we're only 7 minutes away from 7 o'clock, but we can hold on for a few minutes afterwards as well if people have questions. And so just before people doing that, I just want to say, I know some people probably joined partway through this. I think numbers have gone up and down a little bit. If you didn't see the whole thing, rest assured we'll be putting a recorded version on our GoToWebinar platform and our YouTube platform tomorrow. So we'll send a link out directly to all registrants with the direct links to those. Also, this is the final webinar we're doing for 2021, sorry, not losing track. But we've got a schedule we're putting together for 2022. That's coming together now. So we'll be publishing a lot of that on our website in the next, hopefully before Christmas. So have a look out for that. And we'll send the link out maybe in the email we send tomorrow to everybody, just directly to our webinar page, so you'll be able to see kind of what we've got lined up. We're trying to put the whole schedule on for 2022 as much as possible. So just please check that out. Okay, we've got somebody saying thank you very much for the presentation. No actual direct questions at the moment, so
too much clear. You have been too much clear.
That's why I always say, Pietro, if there's no questions, that you've covered everything, and therefore people don't have anything to ask. So it's very good. Yeah, I mean, thank you to you both again for doing this. I don't know if there's anything else you want to add at the end, or so we'll just give it a couple more minutes while people think about it. I'm trying to think what else I need to say to people. I usually haven't got my list in front of me of things to say. Yeah, also, yeah, if you do check out our one tomorrow, we'll send out the email actually for the links to the videos. If you watch the video on YouTube, please subscribe to that as well, and also enable notifications. All of our past ARM webinars are on there as well, so you'll be able to watch those back for those who haven't watched them, seen them yet, or weren't aware of this before. And then we'll continue to put them on there as well. Yeah, so I've not got any questions through, so if no one has any, then we'll say thank you very much, I think, and so I'll give people like 30 seconds now, just in case some people are typing in long questions. Some of them can be. Otherwise, yeah, we can be done just before the hour. So
can I ask a question to Pietro, maybe?
On Pim, yeah, absolutely.
So since you are the expert in this field, I want to ask you, because you have listened to my case, what would you suggest for an operative approach? Can you hear me?
I think you might have frozen there, unfortunately. So I don't know.
It's frozen.
Yeah, we've got a question come through as well in the meantime, so I'm going to send it to you, Pim.
Okay.
I don't know if you can see that.
Can you read the question? Oh.
I sort of sent it through to you, so you should be able to see it hopefully. But
the question is how you can provide a non-accessible colon after low colostomy.
Does that make sense?
No.
Okay.
I don't understand the question.
Yeah, if you want to could clarify that at all, whether you kind of
maybe yeah.
What that word is there, basable might be changing. So please type it again. Pietro's back with us now. So yeah, I think we just lost you there, Pietro, for a second. We can't hear you now.
Very nice presentation. How many patients could you see in the prenatal diagnosis?
We don't have the numbers yet. We are looking at that still. Yeah, I can hear you. Thank you, Pietro. So we don't have the numbers yet to make a statement on that. But for a few years ago, the prenatal doctors didn't look at this. They say we can't see it, we don't know. And since we introduced this and we asked them more and more on what do you see? Can you help us just to look at the perineal crease to see if there's a target sign? They start looking at it, and now they're disseminating it to more hospitals. to look at it. But certainly, if you have another malformation like a single artery umbilical cord, or you have a dysplastic kidney, or a vertebral defect, and then they look at the target sign and they report us wherever it is seen or not.
So have you ever had the opportunity to have a diagnosis of an isolated harm or not? So because
Yes. So we try to also have it more like structurized in the 20 weeks echo, and then we will see it more as an isolated thing. But it's in 20 weeks is sometimes it's still hard to see, and the baby has to be like bottom up in the womb to show it nicely.
Yeah. And then what about the counseling with parents at that point? You know, that's very, if you don't see, you don't see. But if you see, it's also difficult to counsel parents.
Yeah, we don't know the accuracy still. So
Yeah.
we explain what's going to happen after birth and what we're going to do, and to check what is wrong and what has to be done. So for the parents, it's very important to be warned that they can be transferred, that there can be a surgery, because they will be more prepared than if they don't know anything and everything is unexpected.
Yeah. So it's a long way.
It's still a long way. Yeah.
Yeah. Thank you so much.
Yeah,
Thank
Pim,
you.
I've sent you some other questions that come through, so, and some comments as well, really. I think, so if you can see them from, some from Eberhard Schmiedeke. Can you see them, or do you want me to read them out?
I can't see them. I'm sorry.
Okay, I'll read them out. So Eberhard says, let's go through Eberhard's first. He says, Rotterdam uses MRI in feed and wrap technique, Rome the X-ray. And then he said, should MRI be the future and X-ray the past because of not the noxious effect of radiation? And then in brackets, concerning preoperative diagnostics, level of the rectum, distance to the skin.
Exactly. So I think we should move on with these techniques to have better visibility of the malformation. And MRI is becoming more and more available, also with the higher Tesla, with better pixels. And so we can see much more also in these babies. So I think in 5 to 10 years, we will leave the X-ray techniques and do only MRIs.
Yeah, I agree. Now we have to change the look at the looking at the X-ray. We are used to make a decision, but now really we can move toward a less aggressive test. And I agree with you that RMI is probably the future.
So what we do is we explain to the parents that the patient should be sober, nothing per mouth for 4 hours. Then they bring the baby, they feed them, and the pediatric laborant for the MRI wraps them very nice. They put like a kneecap on the bottom, which is the kneecap is used for knee MRI, and it fits perfectly on the bottom, and then they make the MRI. And it gives nice views. If it's still unclear, you can consider to do it under sedation or anesthesia.
Yeah.
Okay, thank you. Yeah, I think Eberhard said thank you very much for that. So already, so I think you answered this question. Laura Dadje said, when should we use closed colostomy after fistulotherapy and anaplasty? I read that correctly.
Okay, thank you. So what we have a protocol we do on the clinic. We check if the anus is patent with Haga dilators without doing harm to the baby. Try to do not many harm to the baby, and then we make a contrast study. The contrast study as such is not strictly necessary. However, I find it always comfortable to see that the rectum is not stenotic. And then after maybe 6 weeks, we close the fistula, the colostomy.
It's almost the same in our practice. We wait 1 month after the PSARP has been performed. We start also with the dilation if they are not painful. If not, we stop or we do under sedation. But this situation is not so frequent in our experience. And then after 1 month after the PSARP has been performed, we are ready to close the colostomy without any other instrumental study or X-ray or other.
Okay. So Emain clarify. I think he tried to clarify his question. That's me. So how can you provide? Please he followed up with a lowerable colon after a low colostomy. Would that make sense?
I didn't understand. What
Okay.
colon?
He's also said, I think, yeah, I'll ask him and maybe we can clarify that again. So we've also got another one from Katja Wolfenbuttel, who says, I guess that cystoscopy is superior to radiological studies to determine the exact position of the fistula. Do you agree?
I think it's not strictly necessary to locate the fistula. It's very useful when you have a proximal fistula, prostatic, or also rectal bladder neck, because those patients sometimes are also difficult to be catheterized. So you can see, you can better see the anatomy of the urethra, of the verumontanum, and also of the ureter, because in those patients the risk of urological anomalies is higher. So you can better define the anatomy of the proximal urethra, and at that point also use you can use the ureteroscopy to put the Foley catheter before the intervention.
Okay, thank you, Pietro. I think that's pretty much all of the questions that we've got.
We have one more question from Ivo de Blauw.
Oh, Ivo, yeah, thank you.
Yes, he asked, do you think ROOF, a roof, is more a problem in laparoscopic procedures or prostatic bulbar fistula than in bladderneck fistula?
Yeah, thanks, Eva, for your question. Roof, I think we underestimate the problem of the roof because we know from short-term studies, maybe then it's not a problem, but on long term, when patients get older, like 56 years old, this roof can be troublesome, can get infections, dribbling, and we should be more aware that we prevent it from happening. So I think from my personal experience, which is maybe somewhat limited compared to Professor Bagolan's, but it's easier to approach the fistula from a PSARP because laparoscopically, what you see is it's on the upper side of your view. You have to turn your camera and look upstairs, and then you follow the rectum as long as possible, but you never know where the urethra starts. So it's quite hard. You only know when the rectum is getting small. From the PSARP side, you can follow the urethra until you see the rectum, and you can nicely take it off. I don't know if it matters if it's a bladderneck or a prostatic fistula. I don't think that's an issue. I can imagine that from laparoscopic view, a prostatic or either bulbar is much harder to follow because it's even deeper in the pelvis.
Yeah, I have more or less the same impression. That is, we started using laparoscopic approach in this higher malformation, and so of course we have not a huge experience, but I think that is more feasible in the rectobladderneck than in the prostatic. I would avoid absolutely, because I find no reason to approach a rectobulbar fistula with a laparoscopic approach. Then I know, you know, everybody know that there is also the risk of malignancy in the roof when you are an adult patient, and in Padua they had one, and other also had some patients because the roof is asymptomatic, so very often is asymptomatic. So I at the moment I have not a conclusive idea. I think that perhaps is a good indication in rectobladderneck fistula, is not sure in the rectoprostatic, perhaps because you can reach the fistula from the posterior sagittal approach without any approach to the abdomen, and in my opinion is absolutely contraindicated when you are faced with a rectobulbar fistula. That's my personal opinion, of course.
Okay, great.
Yeah, there's a follow-up, I think, to that from Eberhard, who says there was no laparoscopic arm repair 56 years ago. The cause of the roof in this adult must have been different, yes.
He's right, of course. But there was laparostomy, so it was an open repair, and then a pull-through that was done. Though it's a Stephen's procedure, I think it's called.
Okay.
And Laura had another question about the use of the urethral catheter. I think during the time of reconstruction, you put in a urethral catheter just to know where the urethra is, so that you don't harm it. And after it, you leave it. You can take it out, but most people will leave it for like a week, just to give the wound some rest.
Yeah.
Okay, thank you both for answering all of those. Quite a lot of questions in the end. So yeah, if no one has anything else, then we are 7:10. So I think we'll leave it there. If anyone does have anything else they've not managed to ask today or would like to, then please send me an email. I can pass it on to people for an answer. So yeah, so thank you everyone to attending, and also many thanks absolutely to both Pim and Pietro for delivering today's webinar. Thank you very much indeed, and I hope we see you both again at some point, whether for another one in the future. So yes, thank you very much, and have a good evening, everyone.
Thank you.
Bye-bye.
Everybody. Bye. Bye.